Hello and welcome to this webinar that is part of the Muscle Working Group webinar series and is organized by EURO-NMD in collaboration with the European Reference Network for Rare Neurological Disorders and the European Academy of Neurology. Today, we are talking about management of cardiac involvement and myopathies, and we are lucky to have with us Professor Eloisa ARBUSTINI from the Fondazione Policlinico San Matteo in Italy, and she is the director of the Center for Inherited Cardiovascular Diseases at the Policlinico San Matteo in Pavia, Italy. She's a cardiologist, a pathologist, and a geneticist that has led major clinical research and research programs on heritable cardiovascular diseases with a patient and family-centered approach that was recognized as a model of excellence. She was the former scientific director of the Burlo Garofalo and director of the transplant research at Policlinico San Matteo, authored too many publications, over 500, and is an active member of the European Society of Cardiology and of the American Heart Association, and a key contributor to the European reference networks VASCERN and GUARD Heart. Her work has been supported by EU national and also regional grants, and she has received multiple awards for her contributions to genomic cardiology. And to have you with us, Professor ARBUSTINI, and the floor is yours. Thank you.
Thank you very much for this very generous introduction. I would anticipate that I'm not here and I'm not presenting my my presentation to teach you something, but more simply to share with you our experience, the way we work with patients with cardiomyopathy in neuromuscular disorders. And I would like to just mention the issues that I will deal with. And first is about TERN, the 24 networks, the classification, the point of view of cardiologists and the point of view of neurologists. The diagnostic problem, which is a big one, our major scope is to move from phenotype to the precise cause of disease in the context of a multidisciplinary care where we provide families with longitudinal monitoring and management. And obviously, I will mention treatments, major treatments up to heart transplantation. Here are my disclosures, my background for those who doesn't know me, in the clinics, pathology and genetics, as was mentioned before. And I would anticipate the problem that we have in the cardiology setting when we approach the issue of heritable neuromuscular diseases, because there are hundreds of different neuromuscular diseases, and the heart involvement is common, but the diseases are different. And in the context of the European reference networks, I'm involved in ENGUARD and VASCERN, but there are at least four realms in which nervous system, a skeletal muscle, in a certain sense involved in terms of activities and research. So my first concept is addressing the nosologies and the classifications. The neurologist point of view, there are many classifications of heritable muscle disorders based on the phenotype, etiology, genetics, pathology, etc. And may be very difficult for us to intake this very complex approach. And reclassification are now emerging, very important. A very good example is for limb-girdle muscle dystrophy in 2018. And vice versa, if you see the cardiology setting, the cardiomyopathies are classified, mainly classified based on morphofunctional phenotype in very few and simple classes. The 4 classes. It goes by itself. I don't know why I'm not able to control. Do you know? Sorry. So just to make an example and to let you understand how working, although we work together, our point of view can be a little bit different, is that in the new classification of limb-girdle muscle dystrophy, the disease gene drives the classification. In the new cardiomyopathy classification, 2023, from the European Society of Cardiology, the morphofunctional phenotype drives the classification. So for cardiologists, we have 5 major groups of cardiomyopathies, and in these 5 major phenotypes, we have to intake all different disorders with many causes, different genetic, non-genetic, etc. Here you see the 5 major types of cardiomyopathy in the classification: dilated, hypertrophic, restrictive. The new entry, left ventricular non-dilated cardiomyopathy, which has been introduced in 2023 to classify those intermediate phenotypes that didn't meet the standard disease definition in spite of the presence of myocardial diseases on cardiac imaging or tissue analysis. And finally, the arrhythmogenic cardiomyopathy. Dilated is probably the most common. Here you see the document, the guidelines, very complex, 123 pages, 1,000, and you see more than 1,200 references. And more important, very important for our interaction today, is that a sentence from these guidelines that states that the multidisciplinary approach to cardiomyopathies as the patient, at their families, and at the heart. So we need a number, very numerous collaborations from many specialists, different disciplines. And of course, we put the heart at the center of our multidisciplinary approach, but you can do the same if you want to put the muscle and have the heart around. Important thing is the multidisciplinary, interactive, integrative approach. And my attempts to link, to integrate cardiology and myology dates back to 2004, when we tried to investigate the skeletal muscle in patients with dilated cardiomyopathy and increased serum CK. And that was a very early research, but it was at the beginning. We didn't have all the tools that we have today. Genetics was done with Sanger sequencing, so very slow, very difficult to complete. And then in 2013, when we proposed the World Heart Federation supported the MOGES classification for cardiomyopathies, in which we simply described, we introduced 5 attributes: morphofunctional, organ involvement, genetic or familiar, and therefore the pattern of inheritance, and the precise cause and the functional status. This was just an anticipation of a more precise classification that we can achieve today using the guidelines. And this approach, very difficult to apply, is actually more a nosology descriptor, multitask. It includes obviously neuromuscular disorders in the organ systems involved in cardiomyopathies. And in 2018, when we tried to make the point on the cardiac phenotypes in skeletal muscle disorders, I'm not sure I've been successful, but to me, it is the integration between cardiologists and myologists is a very important issue. And I would like to
Hi, I'm the paper written by Prof. ARBUSTINI about an innovative classification of inherited muscle disorders. The focus is about the relation between those disorders and cardiological involvement. Inherited muscle disorder are first approached by neurologists, but they involved heart problems, and definitely the cardiologist has a fundamental role. The cardiologist is involved either in the diagnosis of the unrecognized diseases or in the management of the patient. In both cases must provide continuous care. The quicker and precisely the cardiologist is able to do those actions, the greater could be increased the quality of life of the patient. The necessity of a new classification from the cardiologic point of view is unquestionable. Cardiac phenotypes can guide diagnostic suspicion and may also be the first or major clinical manifestation of the disease. Cardiac manifestations includes both cardiomyopathies and rhythm disorders. It's also important to be aware about common biomarkers suggesting cardiomuscular diseases. Here you have a synthetic view of the classification of the cardiac phenotypes and related neuromuscular diseases and muscle involvement. First group, dilated hypokinetic. Second group, hypertrophic phenotypes. Third group, restrictive phenotypes. Fourth group, rhythm disorders and myopathies. Thank you for your attention, and let's talk about this topic together.
Okay, so we can start. I usually anticipate my presentation because the way we see these patients is the one that you have seen before. So if we see a patient with a dilated and hypokinetic dilated cardiomyopathy, and in the context of neuromuscular disorders, excuse me, but I need, okay. At the first, the most important probably condition is dystrophinopathy. With Duchenne, Becker, X-linked dilated cardiomyopathy, but also minor phenotypes such as muscle cramps and myoglobinuria. The second position for sure is limb girdle muscle dystrophy and Emery-Dreifuss muscle dystrophy. So as you see here. And here I show you an example of a couple of brothers affected by X-linked dilated cardiomyopathy. We usually perform endomyocardial biopsy. We are a referral center for heart transplantation, and therefore the biopsy is in the protocol for the listing the patient for this procedure. And the patient showed a typical dilated cardiomyopathy, X-linked recessive, as you can see from the pedigree. The red flag from a clinical point of view was increased serum CK, with the patient shows severe dilation and dysfunction, and actually he was implanted with an ICD because of the very low ejection fraction, but not because of the presence of arrhythmias. The problem is that a simple episode of flu in this patient can precipitate very stable, clinically stable conditions. So now our problem in some cases is the timing for heart transplantation. And here we have, for example, in the first example, this patient underwent heart transplantation, but after the course of many years of follow-up, because the onset of the dilated cardiomyopathy was at 29 and the heart transplantation 10 years later. In this case, a de novo, very rare, it's very rare that we find de novo cases, a variant in this patient, and here you see the biopsy demonstrating the loss of dystrophin expression in the patients versus the normal dystrophin expression in control. And another case here in which we had a rather stable disease for many years, for 24 years actually. And so we could follow the patient and maintain a regular monitoring and treatment during very long time. And again, here another case in which our patient had a very unfortunate combination of DMD from the mother, who was still healthy carrier, and an hypertrophic cardiomyopathy variant from the father. So he's coming regularly and we try to follow his heart. At the moment, we are able to keep the situation under control. And for limb girdle muscle dystrophy. Now, according to the new classification of these diseases, it should be called, I guess, MDM, but perhaps you can better explain me. The family history started with this female, again, many years ago, very long story. She was a swimming athlete, onset at 34 years, still present the atrioventricular block, which is a marker of laminopathies. In this case, the disease gene is lamin, and the mutation is here. She underwent pacemaker implantation, then she was diagnosed with the myopathy, but the function of the left ventricle is still normal, but further deteriorated and progressed, and she is now recently underwent a transplantation. Here, two common forms of Emery-Dreifuss muscle dystrophy, autosomal dominant and autosomal recessive, same genes, probably the recessive is more severe. Laminopathies are typically characterized by loss of expression, loss of function. This is normal in myocardium, and this is a cardiomyopathy with lamin. You can see that the nuclei are completely free. The lamin expression is completely lost in the nuclei. Here in vitro control samples. So from a muscle point of view, the autosomal recessive apparently is a little bit more severe, including partial lipodystrophy, which is not usually seen in autosomal dominant form. But imagine to be in clinics and you see two probants, both are males, both show decreased ejection fractions of left ventricular dysfunction. They both show left ventricular dilation, and both show at the electrocardiogram a marker of laminopathy, and in any case of nuclear envelope defects, which is the atrioventricular block. The difference is in inheritance. In this case, the mother was healthy, but was later found to be carrier or AMD frame shift variant, and vice versa. The other case, similar phenotype, actually was carrier of a lamin defect. Therefore, this is very important for the family, because in this family, we need genetic testing to assess the status of carriers of this, the two offsprings. Vice versa, in this case, we don't need any genetic testing because we can do, obviously, but the female is an obligate carrier, while the male is an obligate non-carrier. So this is the situation. In dilated Emery-Nopathy, females do not show cardiac phenotype, but also muscle phenotype. And in dilated cardiolaminopathy, vice versa, the inheritance is autosomal dominant disease. Hypertrophic groups of cardiomyopathy, this is a big issue, because it is the most common type of cardiomyopathy and is the most common genetic disease affecting the heart. Obviously, I'm sure you know the disorder. Apart from the sarcomeric hypertrophic cardiomyopathy, which is the most common one, we have many genocopies such as ataxia, Friedreich, mitochondrial myopathies, glycogen storage disease, and so on. So let's see, however, how sarcomeric cardiomyopathies may also involve skeletal muscle. This is the MYH7 gene, which is one of the most common, is the second one after MYBPC3, causing hypertrophic cardiomyopathy. All these cardiomyopathies show genetic heterogeneity with many genes that may cause similar phenotypes, but also same gene that may cause different phenotypes. So in this case, MYH7, different mutation may cause dilated hypertrophic cardiomyopathy and at least 4 different types of myopathies. We don't see, it's not frequent in our experience to observe patient carriers of MYH7 defect and myopathies or dystrophy, but mild hypercikemia can occur in these patients. And the protein, in fact, is expressed in both cardiac myocytes and type-1 skeletal muscle fibers, but overt myopathy dystrophy is really rare. But when a hypercemia segregates with a hypertrophic phenotype, but the skeletal muscle signs and symptoms are absent, so the findings remain a descriptive, right? We don't know what to do actually, if we have to do something. More complex are the genocopies of hypertrophic cardiomyopathies, starting from lysosomal defect, glycogenosis, glycosphingolipidosis, mitochondrial cardiomyopathies, and rhizopathies. Friedreich ataxia is a very important disorder, which is caused by defect of the frataxin, which is a mitochondrial protein working in iron hemostasis, and is caused by homozygous guy expansion, the first intron of the frataxin gene. And here we see how recently a very nice paper from this author wrote that Friedreich ataxia is a rare multi-system disease, and obviously involving all these organs and tissues, and including the heart. The Friedreich ataxia, heart is characterized, first of all, is very common to have a heart involvement in this disorder, and up to 85%. And the type of involvement is suggestive of hypertrophic, symmetrical, non-obstructive cardiomyopathies. In the early phases, patients may manifest heart failure with preserved ejection fraction, but in the later stages, the patient manifests heart failure with reduced ejection fraction, so left ventricular dysfunction, and which really condition the mortality, which is predicted by higher repeat expansion, lower ejection fraction, and higher left ventricular mass index. Curious finding is the possible mismatch between the very severe cardiac measurements and the severe and the less severe ataxia, or vice versa. The diagnosis is made with electrocardiogram, two-dimensional transthoracic echocardiogram, CMR, etc. Obviously, the evolution of the disease is progressive. I want to go back, sorry. It's progressive, and from early electrical abnormalities to later left ventricular hypertrophy and fibrosis and then dysfunction. And here you see endomyocardial biopsy of this patient that shows the punctated iron deposits in the mitochondria, which is different from what we see in cardiac hemochromatosis, where the iron is stored in the entire myocytes. Glycogen storage disorders, please, I apologize, it's a very big issue, and there are novel types. Screening studies are going on everywhere. I'm sure that we all know, in case we have patients with glycogenosis, obviously we have a number of collaborations in pediatrics and adult setting, so we are in a good position. Some issues, some problem may occur when we have, for example, cases such as McArdle disease, in this case, in which we have identified not only the mutation in the disease gene, but also a pathogenic variant in a gene associated with cardiomyopathy, titin in this case. And they're very difficult for us to manage these episodes of peaks of increased serum CK that are usually associated with physical exercise, but we usually we have a very difficult time management. We don't know how to do. And another important setting disease in the context of hypertrophic phenotypes is the Danon disease, LAMP2 gene defects. In this case, we have a family in which the mother died while working heart transplantation. The daughter developed ventricular arrhythmias and atrial arrhythmias, but she decided to have pregnancies. So she had 3 prenatal diagnoses. The first one was a negative male. The second one was a positive male, and the pregnancy was interrupted. And the third one was a positive female, and she decided to continue her pregnancy. And here you see, this is her brother, And here you see the endomyocardial biopsy and then the heart explanted at transplantation of the brother, the typical electron microscopy features, but most important, the total loss of LAMP2 expression in the affected myocardium. So this is diseased myocardium, this is normal control. Brown is the presence of LAMP2 that should be there actually normal. If vice versa, in the non-affected female, we see loss of the expression of the protein in many myocytes, but persistence of expression of the protein in some of them, a sort of mosaics. And another important disorder for cardiologists and for neurologists is Anderson-Fabry disease. It's a genocopy of hypertrophic cardiomyopathy. This is a multi-organ, multi-tissue disorder. And see the prevalence of organ involvement are shown here. The heart is the most commonly involved organ. We have very strict criteria for the diagnosis, in particular when we find variants of uncertain significance or atypical variants, whatever we want to call it, endomyocardial biopsy or skin biopsy, very simple to do, or gastric biopsy in case they have some gastroenterological disturbance, clearly shows the accumulation of the substrate GB3 here in brown, and you see here the same, and all these images in the electron microscopy, heart and skin in this case. Very important to make a diagnosis because this is a disease with available target treatments, so we must recognize this patient. Our collaboration with neurologists address more the nervous system than the skeletal muscle, because the central nervous system actually is affected, may show transient ischemic attacks, strokes, seizure, autonomic dysfunction, central autonomic dysfunction, but also the peripheral nervous system, which is very important in children, where we often have acroparesthesia in the extremities and painful crisis precipitated by exercise, fatigue, or stress. I would say also by different intensity, different stimuli. So when we have novel genetic defects in the blood gene, the gene that causes this disorder, we really rely on pathology because it's very simple to demonstrate the accumulation. And we are, as a referral center for heart transplantation, we see patients who are eventually candidate to. And here you see the endomyocardial biopsy with the brown deposits, which are confirmed, but a second tool, which is immunoelectron microscopy, in which the dot, dark dot here is gold, conjugated with the secondary antibody that it goes to the primary target, which is the substrate accumulated in the myocytes. And this was the case of a family recently. We identified this variant in the GLA gene, and this variant was classified as variants of uncertain significance. So was very difficult to define what to do. So we interacted with the family, the brother and the sister, both affected, both carriers, and we decided to perform endomyocardial biopsy. You see similar findings in brother and sisters. Empty myocytes is just because of the extraction of the substrate during the preparation of the biopsy, the accumulation of the GB3, of the substrate within the myocytes, the same section at the electron microscopy, the dark blue here, and the material shown, the accumulated lamellar bodies in the myocytes, specifically immunostained with gold particles. Now, what to do in this case if we didn't have available the biopsy? We could not decide about the pathogenicity of this variant because we in silico criteria were not enough to say this is a pathogenic mutation, this is the cause of the disease. So the reason why we performed the biopsy is because the biopsy allowed us to add the PP2 criterion with moderate restraint, and PS3 criterion with very strong strength, so demonstrating the GB3 accumulation, and by instance also the partial enzyme loss in the female and the total loss in the brother. So the addition of these two criteria shift the cluster from Wuss, Franklin, and our own internal pipeline, or LB according to Varson, to likely pathogenic variant. Important, as I said before, this disease has available treatments that can be enzyme replacement treatment, chaperone, or gene therapy, which is under development, and the substrate reduction, by instance, also under development. At the moment, this is the two one, ERTS and chaperone, are those most commonly used in the clinical practice. Mitochondrial disease is very difficult. I don't know how do you do, but for us it's very complex because the phenotypes are heterogeneous, variable in the same patients. And what we know from a cardiology point of view about MELAS is that cardiomyopathy is information derived from different types of studies. Major studies are those that come from patients diagnosed with MELAS by neurologists and then evaluated and monitored longitudinally at cardiovascular level. And this is typical of pediatricians and neurologists. And cardiologists are involved in a multidisciplinary workup after the diagnosis. But the difficult task for us is when patients are first addressed to cardiologists for the cardiomyopathy and they are undiagnosed, then extracardiac thrites in this patient have been present perhaps for many, many years, but none of them has been considered related with the disease, different disorders. And I'll show you examples. Another important point is that in the historical definition of MELAS, the three invariant criteria are recurrence, stroke-like episodes, encephalopathy, mitochondrial myopathy. And although cardiac involvement is not included in the definition, it can be a lethal clinical manifestation of the diseases. Cardiologists usually do not know this disorder. MELAS in particular, the one that we know better, the 3.2.4.3 variant. What is important for us in managing this patient, first of all, is to make the diagnosis. And the diagnosis can be difficult to achieve because perhaps they have a story of hearing loss years before, and then we think to a Pickarding, or they have a long-lasting diabetes, and then we think, but perhaps this is not a genetic disorder, this is a cardiomyopathy related with a different cause. But there are, if we put together all the trials, all what we see, the diagnosis can be clinically suspected. Important patients with kidney involvement, the involvement can be due both to both focal segmental glomerulosclerosis, which is typical of the disease, but also worsened by the diabetic nephropathy, because the majority of patients that we see in adult life are diabetic. And the problem is when the cardiomyopathy evolves through end-stage heart failure. If it is the kidney, there are evidence of some experience on heart transplantation. This is a conclusion, for example, from a papers in a clinical kidney journal, say this patient should not be excluded from transplant solely because of the mitochondrial diagnosis. But for the heart, we need to be more cautious. There are very few cases. For example, this study from Damien Bonnet, in which he suggests feasibility, but actually he said the clinical results are poor. Other study advise caution in adults, and other studies say, just one case in our series, but they don't give more information. And this is our experience with 65 members of 14 unrelated families, with 14 probants and 40 relatives, 11 disease relatives in these families. Of these 14 probants, 8 died with hypertrophic cardiomyopathy that evolved through dilation and dysfunction, so phenotypically mimicking a dilated cardiomyopathy. 2 actually were diagnosed with dilated cardiomyopathy, died, and 4 are, the monitoring is ongoing. And here is the summary of what we have seen in our series, obviously also in relatives, not only in probants. The heart hypertrophic dilated is rare, hypertrophic a little bit more common, but the most common phenotypes when adult patients come to our attention is hypertrophic dilated cardiomyopathy. So often we miss the hypertrophic phase. The major problem is also the occurrence of stroke-like episodes, myopathy in all our patients, kidney involvement very common, hearing loss all patients invariably, ocular trials less common, endocrine including diabetes in particular in all cases, some bone and skeletal trait. These are patients with very short stature, very typical face. Once you've seen 2 or 3, then you recognize them immediately. And then obviously we have biochemistry with lactacidemia. These are the rules that our clinician has started to learn. Absence of male to male transmission. Females transmit the defect to both males and females. The condition is syndromic. Diabetes and hearing loss before hypertrophic cardiomyopathy or cardiac manifestation. Hypertrophic cardiomyopathy evolves through DCM. Renal failure is very common, as well as myopathy, and the cryptogenic stroke is a big issue also, and a major limitation for our planar transplantation. Facies and skeletal traits in low stature are typical, and the biochemistry that we have seen here is reveal increased lactacidemia. And here is our paper that showed we perform endomyocardial biopsy, abnormalities of myocardial mitochondria, some fibrosis in the heart. And this is a case from 1998. So the most important contribution in this case for endomyocardial biopsy was to evaluate at that time, the heteroplasmy. See, in this position, here we have the highest peak is an A, and here is a G. So EMB is uniquely useful for heteroplasmia in the myocardium. We actually are validating the Oxford nanopore technology. I'm sure that you heard about is a long read sequencing technology that is progressively increasing in the clinical application, in the clinical setting. And here you see how this technology can clearly show this 84% wild type, 60% is mutated, the heteroplasmy. So 64% wild type, 33% mutated, and here 39% wild type and 61% mutated. So phenotype, as I told you, in early phases hypertrophy, in late phases dilation and dysfunction. And here a summary of our family. We fail to give access to heart transplantation or kidney transplantation to our patients. And one of the major reasons you see here, April 2020, here is the brain, and see September 2021. This sudden onset, recurrent cryptogenic stroke, I don't know, these are major problems. And although we had many meetings with our cardiac transplantation team, anesthesiologists, etc., we could not approach any program to heart transplantation. Very common in females is miscarriage. Future, hope for the futures, I don't know. Probably yes, the 3-parent in vitro fertilization. This is from the New York Times, so I didn't put a scientific paper, but there are many. 3 parents, obviously mother, father, and one donor of the mitochondria in case of the female, the mother is affected by mitochondrial disease. Restrictive cardiomyopathy here important because it's a different approach to the diagnosis from neurologists and cardiologists. I often found in the literature cases that were simply defined as cardiomyopathies, but then going deep inside of the data, you recognize restrictive phenotypes. The restrictive heart, both here the small ones are ventricles and the big ones are atria, see, is normal or reduced diastolic volumes of one or both ventricles, normal systolic volumes, and normal left ventricular thickness, but mega atria, big atrium. This is typical of restrictive cardiomyopathy. And here we have the big chapter of myofibrillar myopathies, restrictive cardiomyopathy associated with myofibrillar myopathies. And the myofibrillar myopathy should have as a marker, diagnostic marker, a pathology criterion. And this is the list of genes in which in the literature have been described the occurrence of myofibrillar material in the myocyte. However, in our experience, in blue are the genes who could investigate the corresponding biopsy, the heart, or the heart exercise at transplantation. We didn't find these features. Vice versa, this is absolutely true and is a specific marker for desminopathies, while in particular desminopathies, when we have gain of function variants in desmin, we see typical myofibrillar granule filamentous material within the myocyte. When we have loss of function variants, then we don't see desmin accumulation. To show you why, for example, in the case, the BAG3 is one of the genes associated with the reported myofibrillar myopathy, we saw this specific feature, Z-band, streaming Z-band material abnormal, but not accumulated material. Let's go on. And I like to underline the importance of the possibility that loss of function variants and gain of function variants really are associated to different phenotypes. Here, the 5 types of cardiomyopathy according to the European Society Cardiology classification. If you go on OMIM, for example, you see that desmin defects are associated with all these types of cardiomyopathies, but also including myofibrillar myopathy. So what is the problem? I say perhaps it's the inheritance, no, because the inheritance can be autosomal recessive, dominant, or de novo. In some cases, it remains uncertain when 2 brothers and the father show the same CMR phenotype, but one, and the defect obviously, but one of the 2 brothers in this case is negative. So the marker for us, which is absolutely essential and specific, is the granulofilamentous material that I'm showing you here with the arrow inside of the myocyte. And this is a typical feature of restrictive cardiodesminopathies associated with atrioventricular block. This is a family. We made the diagnosis in 1987. We followed the family since it's still in follow-up. The proband, the stake, actually the proband was the mother at the beginning, but now our patient in follow-up is the one that you see here. He underwent heart transplantation in 1994, and he did very well for 16 years. In 2020, he started to develop the myopathy, and obviously we don't have much to do to support him. So the ultrastructural study assumes the impact of a functional study. So this is a negative myocyte. This is a myocyte from desmin gain of function with granulofilamentous material inside of the myocyte. And this is a truncating variant with haploinsufficiency in the myocyte, which is not associated with the restrictive, but rather with other types of cardiomyopathies. Again, an example, normal, and here with the accumulated material. So I would like to underline the importance of clinicians in contributing to the decision of pathogenicity in genetic variants. We have two major groups of pathogenic criteria in the ACMG classification: the a priori bioinformatic criteria and the clinic genetic and functional criteria. Most clinicians usually rely on reports, genetic reports, based just on a priori and bioinformatic criteria. Vice versa, we think that these criteria are not sufficient, in particular in this case, because we had example of variants, pathogenic variants, that remain of uncertain significance using only a priori bioinformatic criteria. And so the case of inframe, deletions on insertion, or very rare missense variant, but they were classified as FUS. However, the biopsy and the clinical phenotype of these patients were absolutely typical of this myopathy. So after the biopsy, after family segregation study, we were able to show that these two variants, inframe deletion and missense mutation, were absolutely pathogenic. The concept is that we are so used to keep the truncation predicting variants as pathogenic that sometimes we risk to miss the pathogenicity of other variants. So in our experience, patients carrying different these ultra-rare or inframe splicing alteration causing gain of function and producing the granulofilamentous myofibrillar material are associated with restrictive cardiodysminopathy associated with atrioventricular block. Vice versa, patients with truncation predicted mutations or out of frame splicing are associated with non-dilated ventricular, mildly dilated cardiomyopathy, dilated cardiomyopathy, etc. The prognosis is completely different. Most of the patients of the first group undergo heart transplantation in the course of their life. They are young and the phenotype is highly malignant. Vice versa is much less malignant, the phenotypes associated with the truncation predicting variants. The last group, just to mention, is important to make some consideration, because this patient may be asymptomatic and they are not recognized. I'm talking in particular to myotonic dystrophies. Patients are referred to the cardiologist for conduction defects, arrhythmia, or syncope. Cardiomyopathy is uncommon. Also, obviously, skeletal muscle channelopathies, but myotonic dystrophy is more important. In particular, Steiner type, which is the most common muscle dystrophy in adult life, with an estimated prevalence of 1 in 8,000. The cause, is the triplet expansion, etc. But the heart in myotonic dystrophy type 1 is a heart that does not show hypertrophy, does not show dilation, but manifests arrhythmias and conduction tissue disease. Very high risk of sudden death. Left ventricular dysfunction is far less common. It may occur severe, but is usually is not a typical presentation. So we think that joint cardiologists and neurologists, longitudinal care from family can give better clinical results. And I show you why. This is a family followed for 20 years. The first, the lady, dilated cardiomyopathy, laminopathy, heart transplantation, and then the son, and then the sister, and the daughter. And then we are following the young LT carriers of the family. And here you see the 3 hearts in this family. Longitudinal monitoring, again, to do together with neurologists, 1995, 2021. In 1995, these patients showed a sporadic disease from a clinical point of view. Vice versa, at the end of follow-up, monitoring, genotyping, etc. Now we see that is a typical the autosomal dominant myopathy. And this to remind again the case there. What should we do with the myopathy in our transplanted patients after now 20 years of heart transplantation? We are not able to help him. Last few minutes, a couple of minutes, is for treatments of cardiomyopathies in neuromuscular disease. This patient, we should give medication, devices, implantable surveillance tool, ECMO, ventricular assist device, up to heart transplantation, rehabilitation and support. We need to provide all these tools along the natural history of the disease. In particular, disease, DMD management, requires a systematic approach to addressing the cardiomyopathy. And we can use prophylactic and symptomatic treatments as well as proactive evaluation in pre-symptomatic phase disease progression. And obviously, we hope and we foresee new gene therapies. However, at present, we have a very good portfolio of drugs for heart failure that can be used for this patient. I suggest you to give a look to this very recent paper that was published in Cardiology in the Young that summarizes all the steps of the treatment, the very familiar use of angiotensin converting enzyme inhibitors, sartanic drugs and beta blockers we know very well about, mineral corticoids, but also please, now we have new drugs for heart failure, in particular angiotensin receptor neprilysin inhibitors, ARNI, and the sodium glucose cotransporter 2 inhibitor, SGLT2. These are proving to be very effective in heart failure, and there's no reason for us not to provide this treatment to our patients. A major ethical issue can be left ventricular assist device as a destination therapy. There are very little in the literature. We usually, when the few cases in which we had to take decision were very difficult, but one is a case report, another one is a case report. It say, okay, permanent mechanical LVAD should be considered for appropriately selected Duchenne muscle dystrophy patients with medical refractory and stage cardiomyopathy, but see, is a destination therapy. And finally, in 7 cases, the use of an LVAD destination therapy is feasible, suggesting that it may be suitable as a palliative therapy for the treatment of this patient when no other therapeutic options are available. This is a nice paper, give a look if you have time, from Luisa Politano, an excellent neurologist expert in cardiology that has revised the heart transplantation in patients with different type of muscle dystrophy, as you can see here. And obviously the highest number is in Becker muscle dystrophy or X-linked cardiomyopathy, and in Limb-Girdle muscle dystrophy, mainly, I guess, laminopathies, 98 cases from the literature. So heart transplantation in this patient gives very good clinical results. And so this patient can and should undergo heart transplantation. And the immunosuppressive therapy does not affect the skeletal muscle, and heart transplantation is the treatment of choice for patients with advanced dilated cardiomyopathy and mild to moderate muscle impairment. This is very important. So we are not talking about Duchenne, typical Duchenne patient, but mostly Becker and X-linked dilated cardiomyopathy. And we should not fear about cardiac rejection because the behavior is not different from other transplanted patients. Gene therapy, just a couple of suggestions coming from the this recent review, but there are many papers. In case of defects genes with loss of function, the strategy is gene replacement. In case of mutations with gain of function, the development and choices are in terms of gene editing. And these are the ongoing trials in Duchenne muscle dystrophy. And these are my final considerations. Cardiologists and neurologists caring for patients and families with cardiomyopathy in neuromuscular disorder should speak the same language, use the same classification, share any new advancement in knowledge on how to best diagnose, monitor, and treat their patient. And the multidisciplinary care should be centered on the patient rather than centered on the discipline. On cardiology, I have my bed, I have my department, I have my outpatient setting. Trying to find a common point to manage this patient together and providing continuity of care, in particular in familiar diseases, and offering continuity of support and assistance. And personalized care with tailored health plans. This is my personal opinion. I don't know what you think, but guidelines are very useful, are essential I participated in writing the last guideline from the European Society of Cardiology, but no patient is identical to another. We don't have sameness. We have similarities in our phenotypes, but each patient has his own peculiar characteristic and therefore requires a tailored monitoring. And finally, we should work to give patients the best life possible with their disease, prevent fatal events, support them in morbidities, even when unrelated to the primary disease. I don't like the word, I'd like to, to me is enough to survive. No, I think survive is not enough. And here, not complete, but the majority of my coworkers. Thank you for your attention.
Thank you very much, Professor Arbustini. This was a fantastic presentation, and I think everybody is certainly impressed with your multiple disciplinary approach and most of that, and also the fact that you have several hats and that you see problems from clinical, pathological, and genetic perspectives make you a fantastic speaker for a very complex theme. I do not see at the moment any questions in our chat or in our Q&A tool. So I will start. It will help us to probably encourage others to follow up with other questions. So I would start by discussing with you the fact that we have the need for a multidisciplinary approach, but we know that it's easier for us to talk about it than to do it. And I imagine that in the cases of heart transplant for backup patients, you may find some diversity of opinions, not only between cardiologists, but between neurologists and cardiologists. So for teams that are not as articulated as yours, what you think is making the difference to reach a consensus is the fact that you have regular multidisciplinary diagnostic and therapeutic meetings, or that you have a special connection between certain members of the team. What do you think can make a difference and improve the delivery of care for patients?
I think that the real difference is that our medical models of care are entirely centered on the discipline, which is very good for myocardial infarction, for the management of any acute illness. But for complex disorders such as the one that we have discussed now, but there are many, nephrologists could see the same, could have the same problem. You should have the same problem. The integration of the disciplines is really an added value for each of us. I learned a lot when neurologists come here, nephrologists come here and see the patient together with us, or vice versa. We come to the outpatient setting and we see the patient with them. Working together, the multidisciplinarity is not a sum of different consultation. Multidisciplinarity is a way of living medicine. And the genetic approach, the clinical genetic, is an important guide because it takes into account all trials, cardiac and extracardiac. For example, you see the diabetes. The diabetes, we had a problem. For example, we addressed one of our patients with MELAS and diabetes to our diabetology center. And we wrote, please don't give metformin because it can be administered to MELAS and mitochondrial patients. And they say, wow, this is not true. I never had something like that. But for example, metformin is contraindicated. Anesthesiologist, when a patient with MELAS goes to, for example, a minimal dermatological or not necessarily cardiac surgery, anesthesiologists should know which type of anesthesia should be administered to them. So having a precise diagnosis, but also the possibility of helping our colleagues taking care of also minor comorbidities, of all the information that are needed to protect the patients from unexpected complications.
That's fine. That's a very good recommendation. Rabah Ben Yahu has a question. I don't know if he wants to unmute himself and speak live.
I'm read.
So the question is, thank you for your tremendous presentation. In one of your first slides, you said that lamin is absent from the heart of patient, as lamin AC-related disease is autosomal dominant. The normal allele usually compensates the mutated one. Perhaps you want to speak about hemerin-related cardiomyopathy, and that's a question.
Very clear, and is a nice important question, because there are three major defects that can affect the nuclear envelope. One is lamin defect, the second one is hemerin defect, and the third one is RBM20. All these proteins are expressed at the nuclear levels. In laminopathies, those cells that lose lamin expression are typically myocytes. If you look at endothelia, interstitial cells, lymphocytes do not express lamin, but endothelia and interstitial cells, they maintain regular expression of the lamin. And this is because the myocytes are non-cycling cells, not replicating cells. So cells that undergo renewal, they maintain the expression, but vice versa, myocytes do not. Probably the central nervous system is the same. I don't know. It would be very, or at the muscle level would be very interesting to me. As for hemerin, hemerin is the X-linked. The males usually show milder phenotype in terms of dilated cardiomyopathy with respect to laminopathy patients. And the hemerin is shows a decreased expression at the level of the nuclear membranes. I'm sorry, I couldn't show all the stuff that I wanted to show. But vice versa for RBM20, I still do not understand how the nuclear defect manifests in biopsies, because we have very few endomyocardial biopsies from this patient. However, the worst, the malignant phenotypes are in laminopathies, especially in certain mutation. For example, 190, arginine 190 is one of the worst mutations we have seen. And it's a missense, it's not a truncation. It's a variant in which we had at least 8 families with a very high number of transplanted family members. So we hope in new drugs, new trial. There was a trial actually, but it was interrupted for futility, the array trial, I guess from Pfizer, I don't remember. So we still really don't have any tool. We now hope in ARNI, we hope in new drugs to support the evolution of heart failure in this patient. I think they should be considered as Swarovski, no? Take very, very protected and monitored, in particular arrhythmias at first, and then evolution through end-stage heart failure. Hemerin is less severe in my experience.
Very good. So to finalize, we have a question from Professor Conrado Angelini. Please, you can unmute yourself and voice your question, Professor. Well, it seems that we're having trouble. So we are already past the hour, and then I'm going to, in that case, to finish.
Okay. So, ciao Corrado. I'm sorry, I can't say hello to you, but eventually we can talk about.
So thank you very much, Professor Arbustini. Thank you, everybody who was present. Please leave feedback on the form. There's a link on the chat. And next week, there will be another episode of the Muscle webinar series. Thank you very much to all, and bye-bye. Thank you. Bye.
Bye-bye, take care.